Thank you very much, Dr. Faisal Sultan. And I think that I promised you earlier that we would come up with a recommendation for 5 top actions. And I think that is the idea behind this session, that it should come out as a kind of consensus out of this group. And we will surely bring it to you for your attention. Please do stay as long as you can, because at least you'll get a flavor of some of the presentations. With your permission, as the chair, I would like to now request Ms. Samia Shah from my colleague Samia Shah to start her presentation on communications and advocacy. Over to you, Samia.
Thank you, Dr. Zeba. Ladies and gentlemen, our work with youth is driven by 2 key recommendations of CCI related to communications and advocacy, recommendations 5.1 and 5.2, which call for framing of a new national narrative on population, which Population Council developed with the support of UNFPA, and engaging a range of stakeholders, especially youth, for the new narrative to permeate the parlance of younger audience. And this is the work that we undertook with Gates Foundation. Focusing on the largest demographic group of our population, that is the youth, through our research and consultations with youth, we discovered that 3 key areas are important for them in the context of population. First, climate change, employment, and gender equality or women empowerment. We've worked on creating champions among different groups of youth and deliberately steering away from any BCC or behavior change communication. Our initiatives focused on creating an understanding among youth that how tawazun or balance fits into the new narrative, fits into their priorities. So what is the new narrative? The new narrative, next slide please, reads, parents have the right to freely and responsibly decide the number and spacing of their children to fulfill the fundamental rights of their children and family by maintaining balance or tawazun between their family size and resources. The government and society have the responsibility to facilitate parents to achieve this balance by providing universal access to family planning, information, and services, thereby achieving sustainable development goals. Achieving sustainable development. So this narrative was approved by the federal and provincial task forces. Next slide, please. We targeted youth through multiple channels so that we can reach target younger audience at multiple levels. We used traditional media for outreach. We used social media. We used arts and creative writing to reach out to students. We used youth networks. We also leveraged celebrities, and we engaged with the young parliamentarians. Next slide, please. So aligned with the youth priorities, first thing first, we developed products which were used in our interactions with the groups that I had mentioned in my previous slide. For example, we developed an animated video on the concept, explaining the concept of the new narrative, that is Tawazun. We also developed 3 advocacy videos focusing on the areas highlighted by the youth. And we also were able to record a very catchy song by Shehzad Roy on Tawazun. Next slide, please. So with these products and other evidence with us, we went about gaining high-level acceptance of our products through traditional media. For engaging traditional media, we reached out to both government and private sector. With our interactions with the largest Pakistani media group, Jang, a pro bono 10 days blitz campaign using our youth-friendly advocacy video was aired on GeoTV. Through Ministry of Information, we were able to have Pakistan Electronic Media Regulatory Authority to direct different TV channels to use our narrative video and also audio for the Pakistan state radio channels to use as public service messages. For the first time, the narrative in form of a tagline was printed. You can see it's written here, Abadi aur Wasail mein Tawazun, Hum Sab Ki Zimmedari. It was first time printed in government advertisements of 23rd March this year in all the leading Urdu dailies, which has about a readership of about 1.4 million across Pakistan. So really, social media is the new mass media, especially to reach out to youth. So you can, next slide, please, sorry. What we did was, if you could see my slide, Khalisa, next slide, please. Yeah. So we engaged with a number of social media influencers who talked about the cross-sectoral impact of population and highlighted the importance of striking balance for sustainable population in the context of climate change, in context of young mothers' health and other issues like I mentioned in my previous slide. So just to quote one comment on the video that we received in House of Law's video vlog, which garnered about 1 million views, one viewer said, fast-growing population and its impact on countries' resources is a sensitive topic which not many will understand. But the way you have backed up your argument with facts is indeed very useful, and it's useful especially for young audience. Next slide, please. So the other channel that we used to reach out to students was to create partnerships with Pakistan National Council of Arts and National Language Authority to induct the narrative into art and creative writing among students. Through our national poster and Urdu essay competitions, we were able to sensitize over 200 students. You can see one of the winning entries here in the slide. So, but I would like to quote here the winning entry of the essay competition. Adila Arif wrote it from Government College, Birmingham, Punjab. She said, she wrote, government and people have to work together to attain a balance between population and resources. We need to understand that rapid population growth is engulfing the resources at an unsustainable pace. Next up, we collaborated with youth networks who were working on youth issues, especially on reproductive health rights. The purpose was basically to convert these youth leaders into champions for the narrative so that when they interact for their work, for reproductive health especially, and other related issues to environment or education, they're able to promote the new narrative of Tawazun and how family planning is a tool to achieve that balance. Ladies and gentlemen, all of you know that celebrities have a voice which gets heard by a lot of people. We were able to get support of actor Usman Butt and singer Shahzad Roy, who endorsed the narrative in videos which were released on social media platforms. And just a general comment, like people obviously appreciated that they have taken up a very important cause. But one comment I would like to highlight is that one of their fans said that Islam endorses middle path as well. So this is in fact a public endorsement of the new narrative of balance that we have been promoting through these activities. So next slide, please. Supportive laws and policies are very critical for the implementation of the CCI recommendations. And we got about addressing this issue by engaging Young Parliamentarians Forum. So an MOU was signed with PIBS. We had our advocacy seminar on March 16th. Most of the legislators really appreciated the narrative because they thought it helped them change the perception of family planning in Pakistan. It will be easier for them to talk about population issues without fear of backlash in their constituency. So, we think that we were able to take out this conversation out of the closed doors and into their interactions with their constituents. I would like to, again, just to emphasize that the reactions that we got, I would like to quote here Dr. Sayyid Sohail Abbas, who was advisor to the Chief Minister on Law in Gilgit-Baltistan. He said, I admit that this issue is not raised on the floor of the House. I commit today that I will do my best to take up discourse on rapid population growth challenge in the Assembly floor by regularly dedicating time to discuss its impact on country's development and work collectively to prioritize balanced population growth as a critical issue amongst policymakers, government, and general public. So, ladies and gentlemen, this very briefly gives you a picture of our brief picture of the work that we've been doing on the narrative. I would like to sort of conclude my presentation with a 20-second video that was approved by the Ministry of Information for public service messaging on the narrative. But before I do that, I would like to highlight that the outreach that I just presented before you, its cumulative outreach was about for 4.6 million, and that we believe that we were actually able to that we were able to manage for popularizing the narrative. And I think it really needs to be built upon, and the momentum needs to be maintained if the paradigm shift in family planning is going to take place in Pakistan. To quote from one of our advocacy videos, with due apologies to people who don't understand Urdu, but I thought it would be a good ending. So, in one of the videos, this is the line that sort of actually resonated with young people. So it says, "Khayal rakhein, kahin zindagi ka balance out na ho jaye." Thank you. And with this, I would now request Khalil Saab to play the video.
कुदरत का निज़ाम तवाज़ुन पर कायम है।
वसाइल से ज्यादा आबादी के बोझ से तवाज़ुन बिगड़ जाता है।
घर के अफराद और आमदन में तवाज़ुन
हमारी जिम्मेदारी है।
खानदानी मंसूबाबंदी के तरीकों पर अमल करके अपनी जिम्मेदारी पूरी करें।
Okay. Thank you very much, Samia. And Minister Saab, I think two things. First of all, I want to acknowledge that UNFPA supported the whole process of coming up with the national narrative. And this is more a derivative work to really appeal to younger audiences where we really need to change thinking around population issues. And secondly, we would need your help in supporting us. PEMRA has actually issued instructions for this particular video to be aired by private channels and public channels. I think if you like the video and we agree, I think at least it's a start. We should really start trying to coining a campaign and starting it off to influence more and more people. Thank you. Now I will request my colleague, Dr. Ali Mohammed Mir, Senior Director Programs. He will be starting on his presentation on the 5 best bets that we have come up with under this project. These are really the inroads that we think that ought to be made in order to improve service delivery in family planning. So over to you, Dr. Ali.
Thank you very much, Dr. Zeba. These best bets have been identified to provide the federal and provincial task forces with the evidence to prioritize actions and consider options that can help achieve the CCI decisions on providing universal access to rights-based family planning. The first bet that I'm discussing today is engaging men and boys in family planning. Now, international evidence shows that since the ICPD conference, which was held in 1994, there is now a growing recognition of men's important role in family planning and reproductive health across the life course. Globally, various interventions have been used to engage men in family planning. This includes considering men as supporters of women's use, involving men improves attitudes to family planning, changes gender norms, and enhances their knowledge and increases the use of specific methods. There are many examples where peer educators such as Husbands Group in Nigeria, telephone hotlines, and more recently a mobile app, Nivi, developed by the Population Council, used in Kenya, have helped meet men's information needs and leading them to support women's use of contraception. Engaging boys and youth before their perspectives and attitudes are formed is also now being considered an important area to enhance family planning and uptake. As agents of change, men's attitudes have changed by providing them with opportunities to talk about their experiences with other men, such as in men's group meetings and community dialogues. In Pakistan, also the Fala project, which was implemented by the Population Council from 2007 to 2013, used multiple channels such as lady health workers, men's support group, engaging religious leaders in KPK, and the use of interactive theater in the province of Sindh, which was attended by men and women, that resulted in an increase in contraceptive use in the project districts. Next slide, please. Finally, men as users, social marketing programs also have helped increase the use of condoms by enhancing their acceptability and availability. Men's use has also been favorably influenced through male-friendly clinics having trained male providers. Similarly, trained staff at pharmacies and shops offering male counseling have also influenced uptake of male methods. Now, why male engagement is the best bet for Pakistan? Use of male methods is steadily increasing since 1991, but this needs to be further augmented. Men in general and husbands continue to have a major influence on family planning decisions. Yet, unfortunately, boys and unmarried men have very few reliable sources for learning about sexual reproductive health, and they enter marriage with little preparation to delay the first birth or plan their future families. Men increasingly feel that they want to take greater responsibility, but the health system largely excludes them from provider interactions, as our current family planning program remains female centric. In a study in 8 districts in Pakistan, men identified lack of information and services as a major obstacle in using and supporting their wives to use contraception. However, Pakistan is committed to male engagement, reflected in our 2012 policy, the pledges we made at the Family Planning 2020 Summit, and now the CCI 2018 decisions. Next slide, please. So, to include an engagement, we recommend that there is a need to enhance communication channels. Men's commitment to family planning can be enhanced through messaging that links the idea of birth spacing and limiting with their own deep concern to ensure the health and well being of their family. By involving local religious leaders and political leaders as influencers, can help percolate the message of permissibility of birth spacing in Islam to the grassroots level. We also need to increase culturally acceptable and age appropriate life skills based education in schools through the new single curriculum that is to be introduced in Pakistan. We also would like to highly recommend that premarital counseling of the groom and the bride jointly or separately should also be introduced, which is a CCI decision. To enhance service delivery, we can utilize existing healthcare providers to inform and serve men by training and utilizing the existing male providers at the public health facilities. We can reach men beyond clinics through pharmacies, workplace-based programs, mobile messaging, hotlines, and social media, and by ensuring that there are no stockouts of condoms in public sector facilities, especially for the lady health workers, by counseling couples about withdrawal as a backup method, by offering the fertility awareness modern method called standard days method using cycle beads, which is a simple low-cost technology, and by training more providers in non-scalpel vasectomy and addressing myths and misconceptions about this method. Next slide, please. The next best bet that we have identified is engaging the for-profit private sector in delivering family planning services. Over the years, we see that the use of private doctors and pharmacies for family planning services is on the rise in Pakistan. However, there is still a huge potential to expand access as there are over 100,000 family physicians who can be included in providing family planning services. This is based on our discussion with the representatives of the professional bodies of family physicians, some of whom are represented here today. Family physicians are graduate doctors with basic training and are highly trusted by patients and have a huge customer base. Majority of them are male and thus they can motivate and guide men. Male physicians at the same time can also provide female clients with hormonal methods like pills, injections, and implants, and refer for IUDs. Family physicians have existing strong linkages with pharmaceutical companies. However, to be effective, they need regular and uninterrupted supply of contraceptives. They require detailed knowledge about contraceptive technology. And most of these physicians are largely unaware of the unmet need and latent demand that exists. Next slide, please. To tap this tremendous resource, the support and stewardship role of the government, including the health and population welfare departments, the healthcare commissions, and the pharmaceutical industry will be very important. In the model that we have identified, the government's role would entail procuring long-acting contraceptives, IUD, and implants, and provide this to the pharmaceutical partners at a cross price who can use their distribution channels to reach out to the family physicians. The government can facilitate and fund training of physicians and medical reps, establish policies and guidelines as well as standards, and ensure quality assurance, facilitate providers and pharmaceutical partners in addressing regulatory barriers, and also fund demand generation activities like providing IEC materials. While the role of the pharmaceutical industry would be to ensure availability at pharmacies of oral pills, injectables, emergency contraceptive pills, and condoms for prescription sales. The next slide, please. Here we present a business case showing why it will be lucrative for the for-profit private sector to provide family planning services. The main plus is that this initiative, that it can significantly reduce unmet need. Considering certain assumptions, we estimate that there are 5.9 million women with unmet need. Stratifying these women into wealth quintiles, the for-profit private sector can help cater to the unmet need of currently married women of reproductive age in the highest, fourth, and middle wealth quintiles, which comes to nearly 3 million women, or nearly half of the total unmet need of all women. Next slide, please. If we are able to identify and train, let's say, 5,000 physicians in a year, and if each provider provides services to a minimum of 10 women per month for 10 months in a year, they can serve about 500,000 women, or meet 16% of the unmet need of the women from the third highest income quintiles. If on average each physician charges 250 rupees for consultation fees and 500 rupees for a procedure, they can earn 25,000 rupees per annum as consultation and 50,000 rupees as service charge. The estimated cost to the government in year one will be around rupees 870 million, or $5.7 million. Based on current costs, this will include training, oversight, and promotion costs. Commodity costs are not included, as they will be recovered by the government through the sale of pharmaceutical products. The projections will vary depending on changes in the assumptions. The next slide, please. So our final considerations are to implement this approach, a total market approach working group needs to be set up under the stewardship of the federal or provincial health population welfare departments for rules of engagement and effective oversight. Taking several pharmaceutical partners on board could increase scale and reach more clients, while pharmaceutical partners must profit from this initiative. Eventually, the government support should taper off in a couple of years as the for-profit contraceptive market grows, and an understanding can be reached with the government through an MOU to this effect. Now I'll move to the next slide, please, and the final best bet, and the third best bet, which is engaging community health workers in delivering family planning services. Community health workers programs have been implemented globally in many parts of the world, and there are important lessons that we can learn from successful programs. Globally, community health workers have proved effective in delivering preventive, promotive, and curative services, and have been identified as a high-impact practice for family planning. The presence of community health workers has been attributed to increased contraceptive prevalence in many African and Asian countries like Ghana, Ethiopia, Iran, and also Pakistan during the decade of the 1990s. Small-scale community health worker programs implemented in Pakistan also provide very important lessons. We have learned that successful models show that programmatic sustainability is only ensured when there is full government ownership and community engagement. That volunteers have helped program implementation, and that communities are willing to volunteer time and resources for the common good, as has been seen in Ethiopia, Indonesia, and the Iranian model. Teaming up male and female community health workers helps. The Iranian model of male and female behwars enhanced couple communication and increased use of male methods. Next slide, please. Now, based on global evidence, we are recommending that the current LHW model be strengthened by reconfiguring the program. Therefore, for a population of 10,000, we are recommending that there should be 10 female and 10 male health workers, and the female health workers should be supported by 20 village volunteers who can facilitate her work in assembling women and men, spreading messages, and awareness creation. The male workers should reach out to men with services and information and link them to the health system. Both health workers should be part of a primary healthcare team comprising the medical officer, LHV of the nearest BHU or RHC. To indigenize the model, reflecting its restructuring, we can locally rebrand the lady health workers as Bunyadi Sehat Karkun, the volunteers such as Bunyadi Sehat Reza Kars, and the Bunyadi Sehat Muhafiz for the male health workers. The next slide, please. Now, the key innovative elements of the proposed model include introducing mHealth for reporting, monitoring, and remote support from health facilities and logistic management, engaging men directly through the male community health workers, providing the community health workers certified training and a career path, having in place an inbuilt continuous learning mechanism through regular in-depth reviews, community participation embedded in recruitment, supervision, monitoring of the health workers, a referral pathway which includes the private sector. The model does not call for reinventing the wheel. Existing structures can be strengthened and restructured, obviating the need to create new ones. Existing male mobilizers can be retrained and linked to the Bunyadi Sehat team, saving costs. Community volunteerism can be tapped at no additional cost. And finally, a lean version of this proposed model can be pre-tested as a pilot. With these words, I'd like to thank you. And we now move to the fourth and the fifth bet. Thank you very much.
Thank you very much, Dr. Ali. I do say that, we have tried to fit in a lot in this agenda, and I wish we had more time to have a discussion after each of these, but we will have some discussion time towards the end. I'm now going to be moving to the final two best bets, and they both are around financing for family planning. As we all know, this is an area where the evidence internationally and nationally is weak, mainly because the direct data sources such as national health accounts and recording on expenditures seldom really actually collects data on family planning. So the background to this brief is basically that we all agree that finances are crucial. And if we want results to support innovations such as the ones Dr. Ali has talked about and the expansion of the work that Samia has presented, and even globally, we need more financing. And even globally, there's a shortfall in spending as pledged. I may be slightly off about the figures, pledged at the 2012 summit. And out of the 270 million, we have a large amount, almost 6 million of these women living in Pakistan. So clearly, we have to bring more resources to the table. We pledged in 2012 to spend $2.50 per capita on family planning, not quite knowing where we were at. We thought we were maybe above $1 in our current spending. So, and then also in the CCR recommendation number on the finances 3.1, there was the funding was pledged for rupees 10 billion annually to be awarded for this area of work. Next. So, but as I said, we didn't know exactly where we stood. But in 2017-18, we undertook a study with the Guttmacher Institute, the Population Council Pakistan, and we applied the methodology on adding it up to estimate the base cost of the services that are being delivered. And base is based on the essential service package, which is really government level costs, whereas we know already from the slides presented earlier by Dr. Ali that a lot of people are going to the private sector. We found that barely 40 cents rather than $1 that we estimated are being spent on family planning services. And whereas the comparison was very interesting because we also estimated what M&H services were costed, and they were much higher at $5.07. And this is a good comparison because we all know that we have achieved a lot in reducing maternal mortality and increasing institutional deliveries. And obviously that is connected to the higher level of expenditure. Next. So as I said, we know that family planning is a cost-effective intervention, and also we would need to spend less on MNH if actually some of the pregnancies, unwanted pregnancies, were reduced to family planning. But what we wanted to really estimate is what is the total ask if we estimate, in addition to what we're currently spending, what if we were also to meet the unmet need. And we estimated that it would, again, on a very basic just services-based cost, it would cost us 81 cents per capita. And an overlay of 173 million, which is about 90 million more than we are spending now. Whereas with the MNH, the ask was about $2 more than what we are spending. Next. We tried to estimate where the shortfall was. Are all regions spending the same? Obviously, the outlay is much greater for Balochistan, for Punjab, and for Sindh and KP, it's substantial. And the outlay is very little for the smaller regions. But the more interesting fact was the figure is on the right, which is per capita spending. And we find that the regions that are where the shortcoming of spending is greater per capita are really KP, Balochistan, GB, AJK, and FATA. And our first recommendation is that if there is additional spending, we should really make sure at least the unmet need, because these provinces and regions have smaller budgets altogether. Next. Again, if we are to really direct funding, then we should really direct it to improve equity and target poorer households. And we show in the slide that there are about 1.5 million unwanted pregnancies in the poorest 2 quintiles. And clearly additional financing for family planning should really go out to find where the poorest women are and to help them meet the unmet need. On another study done by the Population Council, next, a needy study, which is used internationally for collecting data on family planning spending. We've done the study with UNFPA support for the last 3 years. I just want to highlight one of the findings here. What we found for 18-19 was the spending as reported by the government itself was much higher than what we estimated, 50% higher. It obviously includes a whole lot of other costs than we have estimated. But very important was that 77% of that spending was going to the Population Welfare Department and only 23% to the Department of Health and the LHW program. Furthermore, the spending within all the categories, 66% is going towards salaries, leaving very little room for programmatic expansion. This is an important point going forward. So to conclude, our recommendations are to really, first of all, they reinforce what is already prescribed under the CCR recommendations, that the population fund was meant to match additional funds by the provinces on lady health workers, additional lady health workers being employed, and on contraceptives in particular, and on innovations. So I think we reinforce those findings. We just hope that the government soon will release that fund. The second one is to direct additional funding to regions more cash-strapped, and with minimal additionality, we can meet their unmet needs. And the last one is really to subsidize, particularly out-of-pocket expenses for the poorest women through vouchers, which leads me directly to the last final best bet. Next, please, which is on vouchers for rights-based planning. And I want to acknowledge that this was written by 3 colleagues, not myself. Ben Billows, who was our colleague at Pop Council at that point, Muazzam Ali from WHO, and Dr. Ali Mir, who is my colleague at the council. So, I hope I'm representing your work adequately. They present robust international evidence that vouchers really do, are used effectively, for greater contraceptive choice, to improve equity, and to expand programs. And this also coincides with 2 CCI decisions. 3.1C was really to support innovative approaches for the poor and marginalized. And the second one came under access, that we should actually integrate efforts like these to be part of the social safety net programs that are on the ground. Next. Pakistan does have, they show very well that we have an extended experience with vouchers. And I've just mentioned the best known and best evaluated, perhaps the one that Green Star ran and Mary Stopes Society ran under the Suraj program, and Green Star ran as well. And both of them have in common that they really are, they do expand access, but they more so are directed at expanding contraceptive choice. So I think, whereas, I'll move to the next slide, please. When we revert back to the last brief and when we talked about financing, whereas these schemes and others have done well to introduce contraceptive choice, and it's an essential part of improving quality of care, and they've had an impact on improving contraceptive uptake. We also have to be mindful of this particular chart, and particularly if you look at the leftmost column of those living under $2 a day, there are hardly any users, contraceptive users. So we have to really be boosting that number up. The majority are really going to public sector, 62% of that very small amount, and 38% to private sector. So this is the group we really want to boost up. Next. And based on our research, the extended research over the years, we find that it's really the travel costs, the long distances that poorer women and those living in remote areas have to travel because they live away from markets, they live away from main roads, and the related expenses and lack of knowing where to go exactly from, where exactly am I supposed to find these services, are keeping many women in unmet need. So we basically, ideally, we need vouchers certainly for enhancing contraceptive choice, but also we need vouchers for the poorest women. And the Population Council, the Punjab Innovation Fund, Population Innovation Fund, and the BISP with UNFPA support to us and Government of Punjab directly funding a scheme have tried such a voucher. And in fact, what we are finding that the BISP coming on board was very helpful, because an app that the Population Council has developed allows verification instantly when a woman comes to a service delivery point to really verify that she is in fact from the poorest households. We are giving 500 rupees to service providers, and we've managed, PPF has managed to recruit 60 private providers. We're running this scheme in Rahim Yar Khan. Most importantly, women get 350 rupees for each trip that they make, which is verified. And this has brought forward 20,000 BISP women to get family planning advice and methods. To conclude my presentation, I would like to say that now we have enough evidence that vouchers can be used to increase contraceptive choice, especially to introduce LARCs and implants when they become more widely available, especially in Pakistan. But vouchers can also be used to enhance equity by providing financial subsidies for the poorest. That's how I see the main motivation for the scheme that I just mentioned. And I think vouchers can succeed in inducting additional providers, as was laid out by Dr. Ali. I think, how do we draw the private sector in to give family planning services? But above all will depend on how we are able to upscale voucher schemes into regular programs, such as maybe SAS and other social safety nets or independent programs. And I'll stop here. Thank you very much. And I'll ask my colleagues, Mr. Farooq Azam and Mohammad Khalil, to finally, that is the final segment of our presentation, to present our something we're very proud of, the accountability and monitoring dashboard. Over to you, Khalil and Farooq.
Thank you, Dr. Zeba. This dashboard, which is called Health and Population Dashboard, this was developed through a consultative process where in the provinces and by the international agencies, we received very valuable inputs. So thank you all of you who have contributed in the development of this dashboard. There is a CCI recommendation that emphasizes the use of robust data in monitoring initiatives that are aimed at reducing population growth and improving CPR. So this dashboard is actually in line with that CCI decision. The dashboard not only helps to track progress against the CCI decision, but also helps in strategizing in achieving the related objectives and targets. Next, please. At the there are three levels on which this dashboard operates. At the federal task force level, it helps to compare progress across provinces. We know that the CPR actually changes in CPR takes time, but at least emphasizing the actions which are aimed at achieving the reduction in CPR, those can be monitored. And at the provincial level, those comprise of improving the provincial financing in support of the new initiatives, contraceptive security, also in the any initiatives aimed at involvement of private sector, and including marginalized populations in the services. Then over time, this progress on these indicators can be tracked using the dashboard. Also, the dashboard has the capacity to highlight where the additional funding from the federal government is going to be spent by the provinces. If you recall, there was 10 billion per annum that was promised by the federal government, and as yet it hasn't come through. But that amount is very important as it was aimed at improving the LHW coverage, ensuring contraceptive security, and launch of new initiatives for private sector and marginalized populations by the provinces. Next, please. At the provincial task force level, this focuses on actions for improvement of CPR, setting up a strategic roadmap, by prioritizing the districts which have the highest need, including unmet need, high number of vacant posts, contraceptive shortages, and low LHW coverage, and also rationalizing expenditures, targeting expenditures where the need is the greatest, and also projecting the future need of financing for the next budget and the federal financing, as I mentioned before. You can monitor trends in the uptake of the family planning reproductive health services due to these interventions, and see if you need to improve the strategy with the passage of time. Next, please. At the district level, the focus is on improving the service delivery, monitoring progress on the targets set through the roadmap, and identifying challenges in meeting those targets, which are to be addressed by the provincial governments, including contraceptive supply, LHW coverage, and funds requirement. The way forward is that we are going to install this dashboard in the provinces. Sindh has shown a lot of interest in that already, and the capacity building support will be provided after installation of the dashboard. The dashboard has lots of capabilities. It is a very rich tool, and I would request now my colleague to present it to you. Mr. Mohammed Khalil will do that. Thank you.
Thank you very much, Farooq sir.
Hello everyone. In this short presentation, I will walk you through some of the key features of the dashboard. The Population and Health Dashboard is a web-based dynamic tool. The data on the dashboard is being populated through government data systems, and it has been structured in a way so that it can be scaled up in the future by linking number of other data sets. On the home screen, we have 8 domains of CCI, and from here we can navigate to different pages of the CCI domains to see status and progress of various activities and indicators over time. Mainly, the dashboard works at 3 levels. First, at the Federal Task Force level, the dashboard helps compare progress on key indicators across provinces. Some of the key indicators includes status of task force meetings held at federal and provincial level over time, progress on the specified legislations at the federal and at the provincial level, and available data on finances by province. Then we have unmet need for family planning by province and at the country level. The next indicator is contraceptive prevalence rate by province, total fertility rate by province, total demand for family planning by province. In addition to these indicators, the dashboard also has CCI targets for population growth rate. Here we can see current growth rate and CCI target for 2025 and for 2030. Similarly, we also have CCI targets for total fertility rate for 2025 and 2030, and CCI targets for contraceptive prevalence rate for the year 2025 and 2030. At the second level, the dashboard helps provincial task forces to visualize and monitor periodic data of number of key indicators at the district level. As illustrations, these are LHW coverage, staff presence, contraceptive stocks, etc. Just to demonstrate, we can go to district key indicators, and here we have list of indicators. The first key indicator is to improve FP, ANC and OPD visits at public facilities. The provincial managers can visualize the data by selecting province, type of facility, for example, basic health unit, year, month or quarter, and type of visit. For example, if I just select number of FP visits per 1000 population and then click on view details. After that, the graph on the left side shows number of family planning visits per 1000 population at basic health units of districts in Punjab province. On the right side, we can also visualize geographically that which district is falling into which category. On the same screen, the provincial manager can also track progress between months or quarters. And after that, the graph on the left side shows data for the two time periods, and the third bar shows the progress, whether there was increase or decrease in number of visits during the selected period. But if we look at the map on the right side, we can instantly conclude that in majority of the districts, there was decrease in number of family planning visits at basic health units in Punjab province during the selected period. The second key indicator is to fill various vacant positions in public facilities. Again, the provincial manager can visualize the data within their province and can also track progress over time. For example, if I select KP, type of facility, basic health unit, designation, maybe lady health visitor, year, month or quarter, and then number of vacant posts, and then click on view details. The graph shows number of vacant posts of lady health visitor in basic health units of districts in KP province. Again, on the same screen, the provincial manager can track the progress whether the positions were filled or more positions become vacant during the selected period. The third indicator is to see availability of essential contraceptives at public facilities. The provincial managers can visualize the data for number of contraceptives, and then they can also look at monthly or quarterly progress. Another key indicator is to look at coverage of lady health workers and other health facilities at the district level. The provincial manager can go through the data by selecting province, for example, Punjab, type of visit, year, month or quarter, and then select number of LHWs per 1000 population, and then click on view details. Now the graph shows number of lady health workers per 1000 population in the districts of Punjab province. Again, on the same screen, the provincial manager can compare monthly or quarterly data to see if the coverage of LHWs and other facilities is improved. In addition to these key indicators, the provincial manager can also zoom to a single district and can visualize the progress for all of these key indicators on one screen. So if I select province as Punjab, district, Mandi Bahudin, year, month or quarter, and after that we can visualize progress for all the indicators for Mandi Bahudin district on the same screen. On the third level, the dashboard helps district managers to visualize and monitor periodic data of number of key indicators at the facility level. The same set of indicators which I have just shown are also available for district managers to perform trend analysis and to see monthly or quarterly progress at the facility level. As an illustration, the first indicator at the facility level is to improve FP, ANC, and OPD visits. The district manager can select the province, district, type of facility, facilities managed by year, month or quarter, and type of visit to visualize the data. For example, if I just select number of ANC visits, the graph shows number of ANC visits at basic health units of the selected district during the selected period. All other features of the indicators I have just shown are also available for all of these indicators at the facility level. Similar to zoom to a district feature, the district manager can also zoom to a single facility and can visualize the progress for all of these key indicators on one screen. The dashboard also provides trend analysis of key demographic and other indicators nationally, province-wise, and district-wise. On the district level, we can visualize data for unmet need for family planning. On this screen, we can see unmet need of districts in each province. Then we have contraceptive prevalence rate of all the districts within the selected province. Total fertility rate, again at the district level. Total demand for FP at district level. Population growth over time. On this screen, we can look at population growth of districts for 2017, and we can also go back to previous census years. And similarly, we can also visualize population growth rate over time for all the districts within a province. And at the provincial and national level, dashboard also have population growth over time, again for different census years and by province. The dashboard is capable of uploading data from DHIS, LHWMIS, and CLMIS. These data systems will be linked to the dashboard for automatic updating of the data. MIX, PDHS, and census data are the other data sources which have been used to populate number of indicators. Another feature of the dashboard is that provinces can create users and can also assign different access level to those users on different sections of the dashboard. I stop here. Thank you for your time and attention.
Thank you very much, Khalil. And ladies and gentlemen, I think we have tested your patience by cramming in a lot of, but we're very proud of the work that we've been able to accomplish under this grant. And I think it has direct utility for many uses, even beyond family planning, maybe towards universal health coverage. And we can talk about that in further meetings. I'd really like to now stop us talking and want to hear back from you. And we've especially invited brief comments, but from two esteemed colleagues. The first is Dr. Yilma Alazar, who's Doctor of Medicine, a public health specialist, and he's working as international advisor on family planning at UNFPA. He's a very esteemed colleague of ours, supports us in all our work. And Dr. Talib Lashari, a professional with several years of experience in public policy and in the social sectors. He's currently serving as a technical advisor, costed implementation plan for family planning for the government of Sindh. So Dr. Yilma, if you could start by offering some comments on the presentation.
Thank you. Thank you very much, Dr. Zeba. I just want to say congratulations to you, your team, and also to Gates Foundation for supporting this very important initiative. I always say most of the good ingredients for successful family planning are available in Pakistan, and you properly packaged some of these best practices which should be taken to scale. So even I would like to say the CCI recommendation themselves, the 8 recommendations, the way they were formulated are best practices for me. The reason why I say this is because these were developed based on the request from the Supreme Court, the Chief Justice at that time, and also endorsed by the Council of Common Interest, and then followed by endorsement by His Excellency, the Prime Minister of Pakistan, and followed by also the leadership of His Excellency, the President, to chair the task force, and the same at provincial level also. When you look at this, even the CCI recommendation itself, that initiative for me is something Pakistan should be proud of and be ready to share when family planning population issues are taken at that highest level. So just to say also, when I looked at the title of this meeting, maintaining the momentum of the FP task force, I feel personally it is really timely. And we have to seriously think about the momentum. I came to Pakistan when just like 2 weeks before the symposium, which sort of laid out all these recommendations. So I feel it is time now for us to pause and reflect where we are and how we can further accelerate. And especially since this year we are discussing about the 2030 Pakistan's commitment. We did not achieve the FP 2020 commitment. The FP 2030 is coming, so that's why I feel it is timely, and that's why I like the title. As you said, Dr. Zeba, we have been supporting the government in several areas together with you other partners, especially funding from FCDO, Gates Foundation, Canada, Australia, in the process of the formulation of the recommendations, the action plan for provinces, and also setting the targets, monitoring work, and also the task forces, the national narrative you all described. And looking at the 5 or 6 best bets, I feel they are 100% in line with the CCI recommendations. In fact, most of them will address the relatively forgotten areas of the recommendations. Advocacy and communication, we have to do a lot. The tawazun should sink at all levels, especially at the grassroots level, as a national narrative, as a national motto to achieve the population target for the country, involving the private sector, engaging men, community health worker expansion, reaching the poor through voucher system. And finally, the accountability work. These are all excellent initiatives. And I just want to say, it's also good to make sure that partners beyond Population Council, UNFPA, use these all tools and information that are coming out, the advocacy strategy, the national narrative, the private-public partnership framework, the task sharing, task shifting strategies. These are all linked and tools which were developed since the CCI recommendation. And just on the accountability, I think the dashboard we saw today is very important tool for the work around accountability. With Population Council, we are also trying to bring in the civil society organizations to push the issue of accountability. We will be supported by media and also parliamentarians. And this dashboard, I think, will be an important source of key evidence to push the agenda further. Just to conclude, I just want to say, while we celebrate most of the achievements, I think it's good to also remember we have a long way to go. The high level commitment, as you have seen from His Excellency, the Minister, how he takes this issue seriously, and the same for the President and the Chief Ministers who are chairing the task forces. But I think we have to work a bit harder to take this level of commitment deeper into the provinces and also to the district level, working together. And also, I just want to say the task force meetings should be regular. They're gradually becoming a bit irregular. So how can we make them regular? Because I know senior people are in the room. The promised financial commitments as presented by Dr. Zeba, we are still waiting for the 10 billion rupees, which is not a lot when we see what Pakistan is committing to other sectors. Another important issue is the supply chain, contraceptive commodity security. I think the issue is very complex and it needs holistic approach. So we have to look at it from resource allocation, utilization, procurement challenge, the CLMIs, and human resource aspect. And I was so happy when the minister talked about the structural issues, also about the relationship between population and health. I'm also happy to hear KP government, for example, recently took a decision to merge the population welfare department with the primary health care. This is what we have been waiting for, and this comes at the right time when Pakistan is implementing the universal health coverage. So I would like to take this opportunity to congratulate the government, KP government, and I know similar discussion is ongoing in Punjab, in AJK also. And also the issue of the private-public partnership presented by Dr. Ali deserves attention, because especially the for-profit private sector has a huge potential we have not seriously looked at, and I think we have to look at it seriously. So let me stop here, Dr. Zeba, and thank you again for inviting UNFPA to comment, and congratulations again.
Thank you very much, Dr. Yilma, for those kind words. And you're right, we have a long way to go, certainly, but we're all in it together. And I'm glad to see even at 7 o'clock, past 7 o'clock at night here and early in the morning in Seattle and in DC, we're all here to support each other, still listening to what needs to be done. Thank you very much, Dr. Yilma. Now over to Dr. Talib Lashari for your brief comments, after which we will proceed to a general discussion. Over to you, Dr. Talib.
Thank you, Dr. Zeba Sattar. First of all, I congratulate the Population Council, Bill and Melinda Gates Foundation, and Population Center Pakistan for organizing this very critical discussion and dialogue around the CCI recommendations and some of the best practices that we have heard now through these all wonderful presentations. I think it has been a very important movement for Pakistan, because through Supreme Court suo motu and afterwards CCI recommendations, there is a renewed determination and political will in Pakistan for family planning and reproductive health, and also putting together health and population efforts and departments and ministries to strive for the cause. In this regard, we also know that 4 key areas, at least for the past 5 years, we have learned that political will is very, very critical. Best practices, I'm glad that you have already presented best bets, and we know that these all are best practices through the evidence you have presented. The technical support, I think the political leadership and the governments require a right kind of technical assistance, and timely and to the point. So that technical support provides a lot of ingredient for the implementation. And the fourth one is partnership between public and private sector, for profit as well as not for profit. So I think these 3-4 lessons we have learned for the past 5 years, and we need to further consolidate those lessons and build on those lessons, as well as human development is very important. I mean, building human capital, because we can't work on family planning in isolation, irrespective of the status of women, women economic empowerment, gender issues, engaging youth. So I think these all are very, very critical areas. Lastly, I'll come to the accountability mechanisms in these CCI recommendations. I think the very, very right step has been taken and very important step has been taken by the Population Council and Population Center, that you have developed this dashboard. And I think at the policy level, at the macro level, most of the indicators have been indicated into this dashboard. It's very important for the oversight. It's very important to see what are our targets at the national and provincial levels. And these dashboards are very important for addressing the unmet need at the provincial level and at the district level. And they will also show what is the impact of the interventions and how we can take corrective measures during the course of action, as well as you have shown the trends on population growth, fertility, and CPR. I think these are very important areas where we need to. So this tool will be very helpful at the task force level, at provincial levels. At the same time, a few days back when we had meeting of the CEWG, we had discussed this action plan related monitoring tool developed by the UNFPA and the Ministry of Health Services. So somehow we also need some kind of integration convergence between all our efforts. But I think this effort by the Population Council and Population Center is also very important, and we need to consolidate further these initiatives so that we make the results ensured for a enhanced level of our efforts, and the CPR and the fertility rate must go down, and as well as maternal and new natal health is also linked to all these family planning goals. So I think these all are very, very integrated initiatives. So thank you so much for your time, and I stop here. Thank you.
Thank you very much, Dr. Talib, for your valuable comments. And I want to formally welcome Dr. Nausheen Hamid, our Parliamentary Secretary for the Ministry of Health Services, Regulation and Coordination. Thank you. I know, Dr. Nausheen, you're involved in an assembly session and you found time to join us. We are about to enter the open discussion. I hope there is enough time. I hope we can spill over our session by about 10-15 minutes to incorporate at least the major comments. So I would like to now invite Dr. Yasmin Kazi, who's the Senior Advisor to the Bill and Melinda Gates Foundation on Family Planning. Over to you, Yasmin. If you could just moderate the session, we'd be most grateful.
Sure.
Thank you.
Thank you, Zeba. I would just like to also say congratulations. It's such a pleasure because I've been involved since day zero with this project with you all. So it's great to see that. I was just reading the chat. There are a few things that have come as comments and a question. I think there are questions about the accessibility. Who will be able to, will the dashboard be accessible? There is also a great offer by the Federal Ministry, Dr. Athiya, supported by Kutsia, who is saying this dashboard can be linked with HMIS, and also that, it should be placed there. So I think these are the things that we can definitely, look at later on. But at this point, please, anyone who wants to ask a question or make a comment or just react on what you have seen, please either raise your hand or unmute yourself and say something before, we pass it on to the concluding session. I don't see any hands, so if colleagues are seeing.
Can I speak?
Masuma?
Hello? This is
Shabana. Shabana. Yeah, Shabana, go ahead.
Well, congratulations, Dr. Zema, once again for putting forward the population agenda on the radar of everybody. It's quite forgotten unless you take it on the country level. So congratulations on that. I have 3 or 4 main key points regarding this. I think the recommendations of CCI and what you've proposed is in line with whatever you've said on your 5 best bets. In addition to that, I think it's very important to place population not only as a health issue, but I think we should be placing population as a housing issue, as a water and sanitation issue, as a food, agriculture and livestock issue, and a transport issue. So when we talk about population and FP, we just confine it to issues on health sector. I think we have to broaden the vision for population issues because it is affecting each and every sector. The second point I want to make is that while there's lots of new things to be undertaken, I think it's very important to create synergies with the programs that are already there. Like ESAS is too big now; it's the reach is humongous, and Kamyab Jawan, which is targeting the youth. So these two platforms can we can leverage on whatever is happening and is going to happen on this. Similarly, Sehat Sahulat program or the National Health Insurance program. So these are windows where you don't have to reinvent the wheel. It's just incorporation of family planning in them. So also, the third is the quick wins. I think family planning, if we talk about, Dr. Zeba, you mentioned about vouchers, but if you integrate family planning as a part of the UHC BP, we're working on that. I'm working on the World Bank side for it. If it is incorporated as a part of the universal health coverage package, with the prioritized package, I think that it will be a landmark achievement. Similarly, in the health insurance program. For the tertiary care, we have no program for tertiary care. If it can be incorporated for all tertiary care hospitals across the country. I'm just talking about the quick wins and not talking about any new programs to be coming up. Like you've been doing youth policy dialogues. I think the government on the other end is also doing youth policy dialogues. I think Dr. Nosheen also attended a youth policy dialogue. So we have to create synergies because each person, each government functionary, each department is doing on its own. They're doing all things in silos. So you need to converge at some point in time. Last but not the least, I would say there's too much political commitment now. Let's walk away from the political commitment and let's start doing implementation, because I think we are paralyzing ourselves due to repeated analysis. We know what works, we know where it works, and we know where to work. Now we have to work. So that's from my side. Thank you.
Thank you, Shabana, and thank you for summarizing it so well. So I have 3 hands now. I would begin with Abdul Sattar Saab, because you had first, then I'll go to Samira. Thanks, Samira, for joining, and Dr. Atiya. So Sattar Saab. And please keep it brief so we can cover as many as possible. Ji, please go ahead.
Thanks, Dr. Zeba, and your team. It was really an impressive and enlightening presentation. The 4 keys discussed, it will surely put a dent on other recommendation as well. Actually, I was thinking that the Tawana or the Tawazun Pakistan is Population Council thinking to translate in local languages as well. And the second, my thought is that when the dashboard is going to be used by the provincial governments, this is I want to take on this from Population Council.
Thank you. So if I can have very brief comments from Samira and Dr. Atiya, because then we need to pass on for the concluding remarks. Samira?
Sure, thank you, Yasmin, and it's great to be here. The presentations were very valuable, and we're putting together a fairly big project with the Sindh government that is going to be benefiting and informed from all the information that were presented. Just a couple of points. I mean, we all agree that family planning is a mean to an end. It's not an end by itself, because we want to increase the human capital of all of these women and girls. We want them to be more competitive in the labor market. We want them to be more educated, because educated women, as we all know, make better choices, not just for themselves, but also for their families, especially for their children. So I think this whole thing needs to be packaged within, and I also concur with the universal health coverage comment that was just mentioned. So I think we need to probably have a bigger picture, sort of an outlook into the whole thing, and try and link all of these initiatives, be it private sector or government sector, girls' education, women economic empowerment, towards one goal, which is really increasing the human capital and maintaining all of this quality of life. I'll leave it there. Thank you so much.
Dr. Atiya, if we can have just very brief comments from you. Sorry for pushing but we are running short of time.
Thank you. Thank you very much, Dr. Kazi, and thank you, the organizers. Very informative and very useful information has been passed on to us. I just wanted to, first of all, I wanted to second what Dr. Shabana has said regarding the using the intersectoral approach for tackling the family planning and population issue in Pakistan. And secondly, I would like to respond to her comment of including family planning in the Universal Health Coverage Benefit Package. I would like to inform the House that family planning has been prioritized among the top priority interventions in the Universal Health Coverage Benefit Package. And hopefully this year we will be starting implementation in for the first phase of its implementation will be started in 12 districts across Pakistan. And also regarding including family planning at OPD level, we are also going to a pilot health insurance program with collaboration of Sehat Sahulat program and through Maristopes Society of Pakistan. We are going to pilot it with the support of WHO in ICT, and we will be providing SRH services, including family planning services at the top on OPD basis through at the primary healthcare level through GPs and family physicians. So this has already been taken up by federal government, and we are very much looking forward to the success of this pilot study so that it can, depending on the evidence generated, it will be scaled up across the country. Thank you.
Thank you. Thank you, Dr. Atia, for being such family planning champion for us in Ministry of Health, federal level. Now, I would like to invite my colleague, Elspeth, from headquarters. Elspeth and myself.
Dr. Yasmin, can I just make one minute? Can I make a point?
Okay, Ashfaq Saab, how can I say no to you?
No,
so, yes.
No, thank you so much. I just wanted to thank everybody. I think a wonderful event. I just wanted to emphasize that we should not forget the potential of the private sector providers out there. There's so many of them. They have been largely ignored. They have not been brought into the family planning or the health spectrum. And I think that, they are low-hanging fruit. A lot of investment needs to be made in terms of training, and the supply chain issue has to be resolved. But there is definitely, very obviously, a huge potential out there to really make a dent in the CPRs. And the other point I want to make is, when we were working in Falah, we did reposition family planning as a health intervention. And there is no way out of that. I mean, from a policy level, we can talk about family planning and large populations, but at an individual level, it doesn't really matter. There's a lot more incentive for people to have more children than less. I just want to say it should be brought within the context of birth preparedness, the birth spacing concept, the immunization, the nutrition part of it. All of that makes family planning a lot more acceptable and desirable to the target group that you're trying to reach. Thank you very much.
Thank you, Dr. Ashfaq.
Can I just jump in, Yasmin, and thank Ashfaq Saab. He was one of the authors, main author for the brief on the private sector, and we may have missed acknowledging. Thank you so much with all your breadth of knowledge on Pakistan, having worked on Falah and other
projects. Thank you, Dr. Zeba. I appreciate it.
Dr. Ashfaq from Bangladesh, a great colleague of ours. Elspeth, I would like to now invite you to say a few things.
Greetings, good evening. And on behalf of the Bill and Melinda Gates Foundation, it's really an honor and a privilege to be with all of you virtually, esteemed dignitaries, partners, and colleagues, and to hear about and discuss the great progress made and also the opportunities ahead. Let me foremost express my deep congratulations and appreciation to the Population Council and Population Center Pakistan for leading this very impressive work to advance reproductive health, especially amidst the very challenging circumstances of the pandemic. At the Gates Foundation, there was incredible excitement amongst foundation leadership in 2012 when the government of Pakistan pledged at the London Conference on Family Planning to increase access to contraceptives, and continued great enthusiasm in 2018 when the government created these federal and provincial population task forces And of course, Pakistan's Council of Common Interest developed recommendations on population welfare and family planning to be implemented by provinces and their task forces. So it was really this showing of strong political leadership that encouraged the foundation to invest in complementary efforts to support the government's implementation of these recommendations, of course, under the government's direction and leadership. So we greatly applaud Population Councils and Population Center Pakistan's important work over these past 2 years around the generation and utilization of evidence for policymaking through the work of the Population and Health Dashboard, these family planning best bets analysis and actionable recommendations, and the impressive efforts to engage youth and other champions to grow broader public support for voluntary family planning and reframe the narrative. Pakistan is a priority country for the Bill and Melinda Gates Foundation for many of our health teams, including our family planning and maternal, newborn, and child health strategies to support governmental efforts to accelerate voluntary use of modern contraception among women and girls by both increasing and satisfying demand through expansion of method choice, optimizing proven family planning interventions, and scaling levers, and to reduce maternal and newborn mortality also through scaling proven MNCH interventions and through strengthened healthcare service systems. So I will close by saying that we stand behind and alongside the government and our international and local partners, and we look forward to continued progress ahead to continue to improve the healthcare and rights of women, children, adolescents, and newborns together in achievement of the government's goals and the SDGs. Thank you.
Thank you, Elspeth, and thanks for reiterating BMGF commitment not only to Pakistan but for the work on family planning. So with Zeba, with that, should I pass it over to you, because I think we are running short of time.
Thank you very much, Yasmin. Thank you very much, Elspeth, for your comments. I would like to, if there are no more questions, there are bunches of questions. I think one was around the Tawazun, which I will ask Samia to answer, around the dashboard for Farooq to answer. And there was one on best bets, but if Ali can recall, if he could answer that. So let's start with Samia, a question by Abdul Sattar from Balochistan about translation into local languages, and then
yeah. So Sattar Sab, like in my presentation, I earlier I mentioned that since this narrative has been approved by the provincial task forces, now from what I understand and having attended CEWD meetings, all the provinces are using the narrative, as in the provincial PWDs are using the narrative in their communications. So as such, we haven't translated any work, but since it's already been taken up by the provinces, I am sure each province would be making communication products around their own regional language where required. Thank you.
Farooq.
Okay, there was one question about who would be able to access this dashboard. Primarily, it is meant for the task forces. So at the federal level and at the provincial level, it will be accessible to them. Also to the line departments, because they would be able to do their planning based on the dashboard, the data over there, and setting the targets and then monitoring progress on the targets. Since it mainly uses the government's own data sources, the DHIS and LHWMIS, CLMIS, it is kind of restricted to the official use. It will not be sort of open to the general public, but it depends on the provincial governments where it will be installed, whether they want to make it public, its use. Also, there was a suggestion about linking it up with HMIS, with the ministry at the federal level. Definitely this can be done, and we will talk to you about this and to see how this can be linked to HMIS as well at the level of the federal government. Yeah.
Thank you, Farooq. Dr. Ali, would you like to make some final comments? There were a couple of questions right at the beginning.
Yeah, thank you very much. Yes, I think that one of the comments was about the multi-sectorality of family planning, and that we should have an intersectoral approach when we talk about improving access to family planning. And we totally agree with that it has to be through both the department's health and population welfare. But we've always maintained that the health departments, because it has got a wider and much larger outlay of services, so it's naturally in a better position to improve access if all health facilities start providing family planning services. And for that to happen, two things are very important. One is that there should be availability of female staff along with trained male staff. So we spoke at great length about providing services to men and engaging men. So it's important that the male providers who are present at these facilities must also be trained in family planning. There should be some refresher trainings available for them, and also the availability of female staff to cater to the needs of the female clients. And obviously the availability of contraceptives is extremely important. These are two elements which are important as far as access is concerned. And obviously with that, there are elements of quality of care that also need to be considered. So thank you for that, raising that important point about intersectoral approach.
Okay, thank you, Dr. Ali, and thanks to everyone with their comments. I wish we had more time to have a more leisured discussion, but it will definitely, as I said, this is just the beginning of a long conversations to be had. I would like to now turn to Dr. Nausheen Hamid, who's our respected parliamentary secretary for the Ministry of Health. She's a parliamentarian from the Pakistan Tehreek-e-Insaf. She has been with us in all the task force meetings held at the federal level. She was with us also when we presented our dashboard to the President of Pakistan. She's really a champion for family planning within the ministry. Over to you, Dr. Nausheen Hamid. I'm very grateful for your coming out of the assembly to give these comments. Thank you. Dr. Nausheen, you're mute. Huh?
You can hear me now?
Yes, now we can. Thank you. Thanks.
Thank you so much, Dr. Zeba Sattar. And first of all, I would like to congratulate you on getting all the population champions together and for a very constructive discussion. I missed the earlier part, but whatever I've heard, I'm sure this will help us in going a long way forward. Now, the government and the Ministry of National Health Services holds the CCI decisions and their implementation as an extremely important and high priority. There is total support from the top leadership, especially from the President, who heads the Federal Task Force, and other ministers and CMs who attend. They have collectively expressed support for all actions under the CCI recommendations. The decisions provide a roadmap of the directions we need to take in changing the stagnancy around low contraceptive prevalence rates, high fertility, and high unmet need in Pakistan. Today's important meeting has discussed the avenues of support to maintaining the momentum to support the federal and provincial CCI task forces. This is extremely relevant and useful because it has touched on the core aspects of the CCI 8 areas of priority. It has pointed out many of the directions that we need to move in to escalate our efforts in meeting the CCI goal of 50% CPR by 2025. Advocacy is one of the first priorities that we worked on and got approved by the federal and provincial task forces was the new population narrative, a key task force recommendation, Tawazun. Tawazun is a breakthrough on many levels, but I'm impressed at the multi-level efforts made by the Population Council and the Population Center Pakistan in this program to reach and influence younger influential Pakistanis with this narrative. Advocacy and communications are central, especially among the young, to bring a shift in thinking about population issues at the societal and personal levels. And it is important that the new narrative reaches and influences the younger cohorts. Assess. Some of the important changes that are urgently required to increase access have been outlined in the best bets. Clearly, wider community health worker coverage, especially in the rural and remote areas, and the brief points towards a more effective model that Pakistan needs to take on to link these workers with the public health system. Bringing men into the mainstream of family planning is something we have talked about for several years. And the research from the Population Council already showed us that men are interested in being involved in the information and services for themselves and their wives. The brief has given us a clearer picture of the areas we need to involve them. Men as influencers and users really struck me as important. The brief on involving the private for the profit sector is a clear insight into an approach of immediately escalating access to reproductive health and family planning services. It is clear that we cannot reach universal health coverage without involving the private sector, and here some clear ways forward have been presented. The third, the financing, and the three areas which we should prioritize the rupee 10 billion fund and any other additional resources make the business case for assessing additional funds. We must use the evidence available on financing gaps to make special allocations to the most deprived regions of Balochistan, GB, FATA, and AJK, and the most deprived, poorest communities. The pilot scheme in Rahim Yar Khan of vouchers for transport and related out-of-pocket expenses are really an innovation that must be considered for upscale in poor districts in Punjab and other provinces. The Accountability, Population and Health Dashboard for monitoring the implementation of CCI decisions is very impressive. Data visualization is very powerful. I was with the Population Council and PCP team when they presented it to the President, as Dr. Zeba just mentioned. He immediately saw the significance of lack of family planning services in health outlets and actually decided to visit the provinces personally to follow up on this. And I agree that the meeting could not come at a more opportune time in 2021. We have about 4 years to reach the first goalpost of 50% contraceptive prevalence in 2025. It is the right time for the reflection on what more we can add to our efforts. Today has been huge learning for me, whatever I could hear. And I'm sure what I missed, Dr. Zeba will share with me. And I'm sure for others also that they gained a lot. We thank the Bill and Melinda Gates Foundation for the support of this work and the team who has accomplished a lot in the last 1.5 years. It's always a pleasure to be with you. Thank you so much.
Thank you very much, Dr. Nosheen Hamid. As always, you support all our work and you make sure that it gets through to the right circles. I thank you. I thank Dr. Yasmin for moderating the session. Thank you all for staying here 15 minutes beyond our specified time. And I do hope that you found the session useful. It has also given me a lot of thought, ideas for further work. We hope to take this work together along with other partners. And as I said, the dashboard is something that's evolving a lot, and so are the best briefs. I hope to share these with you, progress in maybe a couple of months down the line in another conversation. Thank you very much for being with us, and Khudafis, and good night, good morning from me. Thank you. Bye-bye.